Good morning. This discussion is going to cover Chapter 24, that is delivering nursing care to the client who is in need of a cesarean birth or a surgical birth. What I do want to point out as we move through this short discussion is that really what we're transferring here is all that you have learned about care of the post-operative client, intraoperative client, preoperative client in your former semester of 112. So it's a short discussion in the sense that you've already demonstrated competence in those areas by completing Nursing 112. And we want to be mindful that we're bringing that to this discussion and then addressing just those very unique, specific pieces that address care of the laboring or delivering is a better word, mother who also will enter into the postpartum or stage 4 of her delivery process. So cesarean birth in this country currently is somewhere between, it depends on what statistical database you look at, but I've seen the reported numbers as low as 26%, the high numbers are at 27.4. I think a safe place to be is around 27%, and that's improvement, because if we were to do this lecture 20 years ago, it was almost as high as 34%. So we've moved in a progressive way away from surgical interventions that really just weren't necessary, and it may have been related to a societal, planning and wanting to know the date of your birth, or delivery, or convenience for the family and provider. And we recognize that there's risk with any surgery. So surgery should be an option for a well-documented, necessary. When we talk about cesarean sections, we do still have a number of births that happen through surgical intervention that are scheduled, but these typically are for repeat cesarean sections, or we know that there's a malposition, meaning like a breech presentation or multiple pregnancy, which would all quantitatively rule someone in for surgical intervention. When we look at that, that's a scheduled event, so it's quite calm, and although it's still distressing for the family because it is surgery, it's something that was anticipated and prepared for, versus the emergent cesarean section. And this would be a situation that arises where the woman would require surgical intervention for things like fetal intolerance to labor. So perhaps mom was laboring and the baby begins to show us fetal heart rate patterns that are indicative that the baby may be hypoxic, anoxic, or for lack of any other term, in trouble. So that would be a good reason. Or we have arrest of labor, it's prolonged labor, prolonged pushing, the incidences of where women are pushing for 4 and 5 hours and we just don't see progression. It could be cephalopelvic disproportion. At that time, that the team has to make an important decision as to whether abort the labor process and go to the OR, the surgical option. Keep in mind that when we talk about the cesarean client, we're talking about all the same effects of surgery that occur in the woman, and then the effects that do occur on the neonate. And I think the greatest effect that it has on the neonate that would be different from their vaginal counterparts would be the retention of some fetal lung fluid in the lungs. We know that the birth process, passing through the vaginal canal, the thoracic squeeze, those things help the vaginally delivered baby to expunge some of that fluid. In the event of a cesarean, there is that slight increased risk of some respiratory issues as the neonate transitions. So the other stresses would be that surgery in itself is stress, right, for the mom's body to recover. It's certainly a major event. Surgery has more stress on the body than a vaginal delivery does. Interruption of self-defense, what do I mean? We're talking about skin integrity. The minute we have an incisional site, we know that there's risk of of infection. So definitely an effective surgery. Cardiovascular risks. So, and you know these from 112, talking about hemorrhage is increased in the surgical client from the surgical site, and the fact that she's still postpartum. So there's still a hemorrhage risk if we have uterine or failure of the uterus to involute, contract, and really clamp down on those vessels to minimize bleeding. And then there's the postoperative risk, of course, of DVTs that we know once they're traveling, it's now an embolus, potential PEs, things like that. Stress on the organs, for sure, it's abdominal surgery. And then those other things that just, managing pain, coping, body image, scar, although today's traditional surgical incision is a low transverse, and rarely do they perform the classical incision, which would be reserved for those super emergency situations, and that would be the up and down vertical. So today it's a low transverse that is typically performed. But keep in mind that women who were not anticipating having a cesarean section and then move on to that surgical intervention, there's a lot of emotional recovery time for them. They didn't anticipate, they didn't plan for this. Sense of failure, which is, I know to those of us who are viewing this as, well, it's a healthy, happy outcome, healthy mother, healthy baby, everyone's okay. There's still a grieving process because it didn't happen the way she anticipated it. The family was planning on it happening. So, there's a delayed discharge, prolonged recovery time, lots of factors here to consider. So, preoperatively, just like your regular surgical client, you need a history and physical, and we're always going to assess those risk factors for our operative or surgical clientele. Looking at her nutritional status, does she have any things that could impact wound healing, like diseases, diabetes, medications, previous wound healing issues. Her age certainly can be a risk factor. Advanced maternal age is anyone over the age of 35. Anything that is altering her baseline health, fluid and electrolyte, her fear, addressing her fear of having surgery. We also have to look at anything about risk to the newborn. Right away, I have an underlying fluid retention. We know is a slight change from the vaginal counterpart, neonate. And then med absorption, how much medication is absorbed to the baby that either needs to get to the baby or shouldn't get to the baby. The diagnostics preoperatively, obviously we're going to get baseline vital signs, a urinalysis, complete blood count to see where she's starting with her H and her whites, looking at those electrolytes, always having a type and screen on hand in case we need blood in the OR, and an ultrasound if warranted to confirm the position of the fetus. The teaching, same teaching as 112, turning, coughing, deep breathing. Postoperatively is imperative to prevent cardiovascular and respiratory complications, as well as the bowel, keeping the bowel moving, reducing the risk of paralytic ileus. The use of incentive spirometry and early ambulation. Interventions preoperatively would be confirming that consent is on hand. Remember, nurses are not legally obtaining consent, but we do confirm consent has been collected. So knowing the difference in how that wording is used in any setting. Prep, right? Is she washed and cleaned the area as directed by the surgical team? GI prep, typically there is not a GI prep for C-sections. If she's scheduled, we'll confirm that she had a MPO after midnight. But if she's a laboring mom, that may not have happened. Setting her up for INOs and any pre-op meds that have to be hung or delivered before the surgery. So, and then tending to the support person is also important here, because most agencies, the policy is that the support person is not called into the OR until after the incision has been made, and then somebody on staff, usually a nurse, will go out and gather the support person, escort them bedside so that they can sit at the head of the stretcher or the surgical table with the mother, and And that's, we want to always be mindful that that person's sitting out in the hallway waiting. You'll notice that I do have things written in red here, and if they're in red, it just simply means that it's important to understand that the C-section, the relationship it has to the newborn. It's important to understand those important diagnostics for consideration in the operative client, the teaching, and the interventions. So, at any rate, so reasons that a woman would require a cesarean section step. This would be your emergency. And we've talked about those on the first slide a little bit. Take a minute here and think about, what do you anticipate is going to be on this list? And I already talked about the fetal intolerance to labor and those non-reassuring fetal heart rate patterns. And I gave you some of the abbreviation lingo that you'll find in the labor world that relate to those things. A prolonged deceleration. So this is a baby who drops from baseline longer than 2 minutes and is not returning. That would be an absolute reason to act on delivering the baby surgically. We talked about the cephalopelvic disproportion and the prolonged labor event. An abruption would absolutely be a reason for a emergency cesarean section. We'll talk about abruptions more in the complicated antenatal and labor and delivery chapters, but abruptions are considered a major complication. And the chief sign and symptom is bleeding. Complete loss of a heart rate, that would be a reason, obviously. And labile maternal vital signs. So a mom who starts to have really significant swings with her vital signs can be a pretty reliable indicator that she herself and her body's not tolerating the labor process. So that's why we pay such close attention to vital signs in the laboring woman. So for the intraoperative care, once we're in the OR, we've completed our pre-op checklist, we've delivered any medications we need to deliver, we've prepared mom for the OR. Typically in the OR, nurses, some of the things that we need to tend to is initiating anesthesia. Now, if this is an emergency cesarean and she has an epidural in place, the epidural can be used for anesthetic management and pain management throughout the procedure. But if she did not have one in place, typically it's going to be a spinal. And oftentimes the big piece for us as the labor team of nurses is to help position mom and prepare mom for that spinal or intrathecal delivery of the anesthetics. Currently, the medication Doromorph is widely used on clients who come in for a scheduled cesarean section. And it's a pretty amazing drug because what Doromorph does is it provides immediate anesthesia for the surgical case, but then it also provides pain relief for 18 to 24 hours. But the mom has ability for sensation to return usually within 4 hours. She has her legs back, she can feel them, she can sense them, she can bear weight. So it's a really effective way to manage pain, the use of Doromorph. However, 2 major side effects. Nearly 50% of women will experience pruritus, extreme itching, after the administration of Doromorph. That is typically managed with a low dose of diphenhydramine to counteract the effects of the itching. The other one is in rare cases, respiratory depression, and that can last as long as the effects of the drug, the 18 to 24 hours, which means that women who receive Doromorph would be monitored closely for the need to have diphenhydramine for the itching and respiratory status. So respiratory rate hourly, O2 sat hourly. Other things that we would be focused on in the intraoperative phase is skin preparation, and that's the swabbing of the skin. Oftentimes that's the surgical tech or the sterile nurse, the surgical nurse, who's doing the skin prep and timing it to make sure that it is dried and been applied for long enough. Assisting in setting up, understanding the incisional access, whether it's a classical, and then the birth process, and that is that once the baby's born, all the things that you learned in that chapter about banding the baby, identification, making sure, obviously, the baby's transitioning well, and then bonding, really getting mom right, getting the baby to mom as fast as we can. There was a time in surgical settings that the baby was not brought to the mother. The baby would go to the radiant warmer. Today, more and more facilities are facilitating and encouraging that the baby is born, dried, and then just walked right up to the head of the stretcher or the operative table, where the mom can, at the very least, see the baby and really putting the baby on her chest, skin to skin. That's the end of part one. I'll begin part two next.